I'm Jonathan Friedberg from the University of Rochester, and I'd like to thank Drs. Coleman and Leonard for the kind invitation to participate, and in particular, congratulate Dr. Coleman on his award that he got earlier in the meeting. Following Dr. Bartlett's discussion, I'm going to move on to talk about novel agents in follicular lymphoma, specifically PI3 kinase inhibitors, EZH2 inhibitors, and novel antibodies. The disease follicular lymphoma in 2020 is a very interesting disease, clearly. And for most patients, outcomes are very favorable with our current therapeutic armamentarium. And in fact, most of the patients that we see may respond very well to an initial treatment regimen and not need treatment for up to a decade. We know that clonal heterogeneity exists within follicular lymphoma, and because of that heterogeneity in part, that currently limits precision medicine approaches to treatment. As I'll show you, the clinically defined subset of patients with early progression after initial treatment reproducibly has short survival, and novel approaches may hold particular promise for these high-risk patients. There have been a number of prognostic scores for follicular lymphoma that have been developed. The M7 FLIPI is a score that incorporates biologic mutational analysis with the clinical FLIPI group. This scoring system has not been able to move on to help us decide on treatment. And the reason is that low-frequency clones at diagnosis often contribute to therapy resistance and transformation. These may not even appear in the routine genetic and molecular studies. So the M7 and some of these other newer schemes are prognostic, but none of them serve as predictive biomarkers. We're hoping in the future that the use of circulating tumor DNA may accelerate progress in this area. However, until then, most of our clinical decisions are somewhat empiric. So as I mentioned, early relapse is associated with high mortality in follicular lymphoma. And these are curves from two representative cohorts that demonstrate that patients who progress within 2 years of initial chemoimmunotherapy have relatively short overall survival, with a median overall survival of 5 years or less, as compared with those patients who do not experience early progression. And this has been reproducibly identified in several subsets. And we'll keep this in mind as we go through the data on these new agents, because the question is whether any of the new agents may help impact this group of patients. This group of patients has been identified as the highest priority follicular lymphoma population by the National Clinical Trials Network in a clinical trials planning meeting. And I'll show you our current trial in that space that is enrolling patients in North America. So I'm going to start with a discussion on obinutuzumab, which is a novel anti-CD20 monoclonal antibody. This is a drug that is a humanized antibody, and it's designed to have tighter binding to CD20, which theoretically should improve a cytotoxic cell kill associated with that binding. The trial that it was most relevant in upfront follicular lymphoma was the Gallium Trial. This was a phase 3 trial that compared obinutuzumab with chemotherapy compared to rituximab with chemotherapy. And both groups also got maintenance with the same antibody. This was a large study that enrolled over 1,000 patients with previously untreated follicular lymphoma. And you can see that the investigator-assessed progression-free survival was statistically improved with obinutuzumab as compared with rituximab. Whether this is clinically meaningful or not is up to certainly the treating physician, but I will point out that these curves separate early, and if you look at that critical 2-year time point, the 2-year progression-free survival in the rituximab group was 81%, and in the obinutuzumab group was 88%. Now, in this trial, part of the reason for that is that the achievement of MRD undetectability was higher in patients that were treated with obinutuzumab compared to rituximab. Some of this was clouded by the chemotherapy regimen that was used, but you can see here that the obinutuzumab group did achieve MRD negative status at a higher rate, and that may explain that the remission is actually deeper. And this shows you that if you did achieve MRD negativity in that trial, of course, your outcome was better as compared to being MRD positive. Now, there's a cost associated with the use of obinutuzumab, and it is a higher toxicity regimen as compared to rituximab. So although we see the highest response rates with bendamustine chemotherapy and obinutuzumab, there were some increased deaths observed in remission during the maintenance treatment following bendamustine. And one explanation for that is in patients treated with bendamustine, their CD4 counts get quite low, almost at AIDS levels, and then there's a slow gradual recovery within 2 or 3 years. We do not see that with CHOP, and this does set patients up for the risk of opportunistic infections, particularly if you're combining this with a potent anti-CD20 antibody. Now, if you look specifically at the group that had early relapse, the use of obinutuzumab was associated with a 34% reduction in the risk of a PFS event at 24 months relative to rituximab-containing chemotherapy. And I'll point out this manuscript that was published last year that details this patient population. The question is, will this ultimately impact overall survival, or could we just use obinutuzumab in the relapse setting? And I think that's what many of us are doing now, but we're going to have to follow these curves closely over the next few years. The other study with obinutuzumab is the Gadolin Trial. This was in patients who were refractory to rituximab, meaning no response or progression within 6 months. And they were randomized in the relapse setting to either bendamustine alone or the combination of bendamustine and obinutuzumab, followed by obinutuzumab maintenance. And this trial did importantly show an overall survival benefit to the combination of bendamustine and obinutuzumab compared to bendamustine alone. And you can see that on this curve with a significantly increased number of PFS events with bendamustine alone, as well as the overall survival improvement. This was with a median follow-up of about 3 years. So if we put all this together, the question is, is obinutuzumab really a better antibody than rituximab for follicular lymphoma? I think in the laboratory, there's evidence that it is. And in people, clearly, when you combine it with chemotherapy, there's a small but statistically significant benefit with obinutuzumab-containing regimens. There's a survival benefit when you combine bendamustine with obinutuzumab compared to bendamustine alone in relapse and refractory setting. And we do see improved MRD and response duration when combined with upfront chemotherapy. The Gallium study was particularly challenging to interpret because the biggest impact of obinutuzumab was seen when CVP was the chemotherapy partner. And of course, CVP we know is less potent than bendamustine or CHOP. So again, my take home on this is upfront, we have to wait for overall survival benefit, although obinutuzumab is clearly an option. But in the relapse setting, I think it's a very attractive option, and with the observed survival benefit is my preferred antibody. I'm going to move on now to discuss the use of PI3 kinase inhibitors in follicular lymphoma. And the first drug I'm going to just mention is Idelalisib. This drug was studied in a group of patients with indolent lymphoma that were refractory to rituximab and alkylating agents. So what they call a double refractory population. And the majority of patients, 72 patients in this waterfall plot, had follicular lymphoma. And you can see the follicular lymphoma is this light blue color. The overall response rate was 57% with a low CR rate, and the median progression-free survival was about a year. And this led to FDA approval in relapsed follicular lymphoma in patients who have received 2 prior systemic therapies. And I'll point out that many of the patients that didn't respond still derived some clinical benefit as far as lymph node decrease. If you look at the subset of patients that had the high-risk follicular lymphoma or early progressing follicular lymphoma that I identified at the beginning of the talk, these patients also had a significant response rate, and you can see that the waterfall plot looked very similar to the one that I just showed you. However, the duration of these responses was shortest in the patients that had very early disease progression after initial therapy, and in the 12 to 24 month time frame was a bit better. Now, there's a black box warning for Idelalisib, and I cite on this slide a very nice review of toxicity management with this drug. But specifically, you have to look for hepatic complications, severe diarrhea, colitis, pneumonitis, and intestinal perforations. And therefore, over the course of giving this oral therapy, you have to be monitoring liver function, symptoms for diarrhea and colitis, pulmonary symptoms, and of course, if any intestinal perforation may be present, have a low threshold for imaging. In addition, generally we monitor CMV reactivation, as well as giving pneumocystis and antiviral prophylaxis. And I'll just say with some experience, these side effects can be manageable, but you really have to be aware of them. They can sneak up on you, and a patient can be doing fine for 6 or 7 months on this treatment, and then, for example, start to develop diarrhea. And you can't just attribute it to food poisoning or something like that, because sometimes severe colitis can really become a problem several months into the treatment. Now, another PI3 kinase inhibitor that is approved in this setting is Copanlisib. This is a drug that has a slightly different mechanism of action because it's not just the pure delta isoform that this inhibits, it's also the alpha isoform. Interestingly, the waterfall plot with this single-arm trial looks almost exactly the same as far as response as Idelalisib. The blue here is the follicular lymphoma patients, and the overall response rate was about the same with a similar CR rate and duration of response. The toxicity profile is slightly different. You can see liver function test increases and cytopenias, but because of the alpha inhibition, there's also risks of hypertension and hyperglycemia. These tend to be transient after administration of the drug, but sometimes the hyperglycemia can be severe if the patient has underlying uncontrolled diabetes. Within the manuscript for Copanlisib, there was the beginnings of searching for a precision approach for this drug, looking at specific gene expression in PI3 kinase and B-cell receptor pathway genes. And you can see that most of the responses occurred in patients that had high gene expression of these pathways. And this is the beginnings of where we may want to go with this class of drugs. And I'll emphasize that in patients with early progressing follicular lymphoma, we have an open randomized trial in the cooperative group. These are for patients who relapse within 2 years or are PET positive after either CHOP or bendamustine-based induction therapy. And those patients are randomized to either chemotherapy with obinutuzumab, lenalidomide and obinutuzumab, or umbralisib and obinutuzumab. And umbralisib is another PI3 kinase inhibitor with similar activity and toxicity profile to Idelalisib. I'm now going to move to the newest class of these drugs, which is EZH2 inhibition in follicular lymphoma. EZH2, I'll remind you, is a predictive of outcome, and it's actually a favorable mutation within the M7 FLIPI. About 20% of patients with follicular lymphoma harbor EZH2 mutations, and those patients on average have better outcomes than patients who do not harbor that mutation. Presented at ASH last year was a phase 2 study of tazemetostat, which is a specific EZH2 inhibitor. This was in follicular lymphoma, and about half of the patients had mutant EZH2, and the other half of the patients had wild-type EZH2. And I'm putting the demographic data for the trial up on this slide to just make a couple of points. First, these patients were generally heavily pretreated with a median of 2 or 3 prior regimens. But if, as I explained, patients with mutant EZH2 tend to have more favorable disease. So they were less refractory to rituximab, less of them had prior stem cell transplants, and less of them had early relapse to their induction therapy. Treatment with tazemetostat was generally well tolerated on this study. I show you on the slide the percentage of patients that had treatment discontinuation due to adverse events. And most of the toxicities were of low grade and were things like nausea, asthenia, diarrhea, and fatigue that could be managed. There were no treatment-related deaths on this study. This is the waterfall plot of the response in the mutant EZH2 cohort. 98% of patients had tumor reduction, and you can see that the majority of patients had response. Now, interestingly, there were also a reasonable number of responses seen in the wild-type EZH2 cohort, although clearly this wasn't quite as favorable as the mutant cohort. And similarly, the progression-free survival curves, very early at this point, so it's very hard to assess durability, did favor patients with mutant EZH2, with a median progression-free survival of almost 14 months in that group. So the FDA approved this drug recently in June. And the approval, as underlined here, were for adult patients with relapsed or refractory follicular lymphoma whose tumors are positive for an EZH2 mutation, or for adult patients who have no satisfactory treatment options. And along with the approval was a mutation test. I'll just mention at the end here in one slide the fact that CAR T is also a growing option in this space. And at the ASCO meeting a few months ago, the initial results of the Zuma 5 trial were presented, which is a CAR T approach for follicular lymphoma. This trial enrolled patients with high-risk indolent lymphoma that had 2 or more lines of prior therapy. About 2/3 of these had the POD24 or the early relapse, so were high-risk patients, and 73% of them were refractory to their last treatment. The data set included 80 patients with follicular lymphoma. Almost all of them responded to CAR T, and 68% of the patients had ongoing responses at the time of the abstract presentation, with expected cytokine release syndrome and neurologic toxicity for CAR T. 2 patients died from the CAR T. And as a result of this trial, Kite has submitted a supplemental biologics license application to the FDA to expand the indication for their CAR T product, axicabtagene ciloleucel. And I expect that the FDA will likely approve that expanded indication based on this trial. So when we're thinking about novel agents, we also have to think about where CAR T fits in. Just a couple of final thoughts and conclusions. So obinutuzumab given upfront with chemotherapy modestly improves progression-free survival compared with rituximab. In the relapse setting, however, obinutuzumab is my preferred anti-CD20 antibody in follicular lymphoma. PI3 kinase inhibitors are active agents in follicular lymphoma. Subsets of patients achieve durable response, but because of toxicity, I generally reserve these drugs for late in the course of the disease, and I prefer agents like lenalidomide as second-line therapy. We talked about tazemetostat as a newly approved EZH2 inhibitor with activity in both mutated and wild-type patients. Because of the availability of this agent, I am now testing patients for EZH2, and if they're mutated, I will preferentially use this agent. And finally, I'll plug the US Intergroup S1608 trial, which is an important study targeting patients with follicular lymphoma and early relapse. It's available on the CTSU, and I encourage everybody to participate. Thank you so much for your attention, and I look forward to the question period in the panel discussion.